move to our next presenter, Dr. Praveer Agarwal. A big hand to Kirti again for a great presentation. So Dr. Praveer Agarwal is my colleague at Fortis Escorts Heart Institute. And if somebody may correct me, but he's probably doing the largest number of Rota ablation cases in the country, amongst the top people. And he has a vast experience of doing all kinds of complex rotas. At times we really see with open eyes that how he gets into those difficult cases. So was there any more comment? Dr. Bhupati, did you want to make a comment on the media versus intima simplified into IVL?
Actually, my question is to Dr. Kirti. If Dr. Kirti Punamia, there are many operators sitting here across the country. If there is no availability of excimer laser and there is a calcified lesion in the cath lab, of course, all these devices, what we are seeing, IVL, and they're all not very cost effective, because we represent a country where the cost is one of the very important factors. So if we have to deal with what is the simplest message you want to give to the audience when you come across a calcified lesion, what is your simplistic way of treating it? Is it a Rota? Because other devices, sometimes they may not be available.
So I think this is working. No, it is not. Okay, now it is. Yeah.
Short comment,
There is no simple answer to calcium. That's one. So when you say that, what is the simplistic way to deal with calcium? There is none. Two, because calcified arteries are very unpredictable. So you will need to go to the Chinese War Bible, the set, which is talked about a million times. When you go into a war, go well prepared or don't go into it at all. So I refute you on 2 points. It's not cost effective. Sorry. We don't know, and we don't know that answer, because I think it is expensive, but it is effective. So when it is expensive and effective, it is still something that you can't deny your patient. You cannot make decisions for your patient. One. Second, if you really think that the calcium is out of hand and you cannot handle it, then you shouldn't do it, because there are surgeons who can put in a graft to those arteries. So I think the reason we are having this session over here is to identify what can be done. What can be done within the boundaries of safety. And that will change in every row of this audience, because every person will have a different cath lab, different abilities, and different devices and tools. But only you can decide what is safe in your cath lab.
That's great.
Very well.
Praveer, over to you now.
I have to make one comment, sir. So we have a case severely.
We'll have a comment after this case, please.
Okay, fine.
Okay, thank you.
Thank you, Dr. Mathur, for inviting me for such a happy excellent gathering
Mike.
Hello? Am I audible? Hello?
Yeah.
Now audible.
Oh, okay. Right. So after seeing the Kirti's cases, I think I'm just talking of the routine daily cases that we keep tackling, and where, as the topic is, Rota is not always a cakewalk. It's not. If one is not doing it in a routine way, then certainly you can have problems. So I'll show some very simple cases, but taking a decision right in time that help the patient. Like the first patient is about a 63-year-old male patient, diabetic hypertensive, stress is positive, calcium score was very high, the CT angio could not have been done. Angiography revealed single vessel disease, proximal lesion, which is heavily calcified with some acute bend there. Now, if I look at the angiogram, the RCA is normal, circ is unremarkable. So that's the lesion in the LAD. Multiple views to just define this, and heavy chunk, and a very tight lesion at the bend. So seeing this scenario that you're always fearing that there's a bend there, heavy calcium, and even a person that we routinely do Rota without fear, you always want to avoid Rota here if we can succeed without that. So seeing this bend, I decided, look, let me just try without Rota if possible on day one. So we put in 2 wires there to just make it more, I think, support. And see, after stretching, it was apparent that it might work. But no balloon goes. The smallest balloon is 1 into 5. It did not cross. We tried for a couple of minutes. We knew that even if it crosses, it will not make room enough to do the procedure. And we planned as according to we wanted to avoid Rota, but the very next day that we took him again, we took some views to see that how the wire bias will happen and whether we will go outside the vessel or not. It's acute bend and you're going with the Rota there. So there's the Rota wire in place now, the next day. And in this scenario, I would not be very happy to take a very bigger, but it's acute bend and the calcium is very heavy there. But the only thing is that you have to go very slow. You have to give time to drill, not to push. If you push, you are in trouble. So a very gentle Rota, and you can see like there's no hurry in that. You're taking a thick of calcium. And the wire bias is also favoring you. You can see that very well. Very gently we are going through. It was about 3.5 or 4 minutes before we could cross this lesion. Right. Once you do that, now the things are fine. The same 2 wires. And see, this is an Oxford balloon, used balloon, goes in without any resistance. So that's the magic of Rota once you are doing that. So once you do that, it's not a problem at all. So you're okay. The only thing is that in that kind of scenario where the acute bend is there, you're always fearing that the Rota might damage you in case you are using it like in a haste or like that. But if you use it very carefully, it's okay. It's a 3.25 stent deployed at high pressures. And you can't be on very high pressure because you know you're on a bend, you put in a Rota burr there, and then you are dilating it. Don't be too aggressive. And that's the reasonable outcome in that scenario. Now, see the next case. He's again a 63-year-old male, long-standing diabetic, unstable angina, normal LVEF, corneal angiography, left dominant system, moderate disease in circumflex, LED, patent stent in distal LED done a few years back. Now he comes with a dense lesion in the LED, which is densely calcified, and a huge bend there. Just have a look at the pictures. See this bend. So it's a bad one. We knew that it's a bad one. It's going to give us some trouble. So the Rota wire in place. And it was difficult to park even the Rota wire in the mid LED, but it was possible. And now see, we are drilling it. So considering the upfront Rota with 1.25 burr, because it's a very, very small lumen there. Now see this. This picture has to be seen it very carefully. You see this burr is striking at an angle. And in a calcified vessel, when the Rota wire goes, it does not take like a gentle bend. It's basically a kink there because it's a calcified lesion. So you have to be gentle till this bend. You can't go aggressive on this bend. So after doing for about, say, a couple of minutes, about 5 minutes, I decided to look, now this could not only take this bend. If I go aggressive, I may damage and I may go perforate the artery by just cutting the wire through, right? So we just decided that, look, now we should just take whatever we have got now, and we just take it as half Rota and see that how we can succeed. So now the 2 wires down, we took it as a half Rota, but the balloons go in. It's an NC balloon opening up. This is balloon ruptures distally. Go, 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 go. Yes, it ruptures there. It means there's not enough room there. Still, the calcium is quite inside. So you take another bigger balloon. It's a 2.5. That was the size decided for the LED stent, right? It's a very smallish vessel. There's a 2.5 like a non-compliant balloon, making a good room there before you take the stent down. That's a 2.5 into 23 stent deployed at nominal pressures, and then again go high pressure inside to just make a good room there. And it's a reasonable outcome at the end in such a bad lesion. Still is doing pretty well. It's done recently. Can I take a few more minutes? Right. So another case is a 48-year-old male, he's a long-standing diabetic, end-stage disease on regular hemodialysis, and recurrent episodes of unstable angina on dialysis. So his angiography was done like he got daily angina on dialysis, and so see the angiogram. His left system is unremarkable. So after seeing this angiogram, people will think that this can be just a routine, maybe thrombus. Right, because left side is totally unremarkable. It's totally normal arteries. It's a huge artery with a picture like that. But we keep seeing that they are like daily. Like, these are not like thrombus leading. This is a lot of calcium is there. Now see, when we start doing plasty on that, these are the routine wires that we tried. That look, this may be a thrombus, but I was very sure it's not a thrombus at all. It's a calcified lesion with a thrombus, maybe a part of it. The wires are not crossing through. Now see, this one balloon goes in, ruptures at 14. Now, no balloon can enter that. So we knew that it has to be drilled before we can do anything on that. Now see, it's again, like some space has to be made. And now see the drilling, how eccentric drilling is happening. I'll show you the next view. It's coming from out to inside. Just see this, right? And this was after a couple of minutes, not a very thing. Like, so here you are scared that look, you may cut through and you are just going from one end to the other end. It's just diagonal cutting. So here we decided this, it's a thick calcium there, made some room with the balloons. Now the balloons are going. This is a 2 balloon, then a 3 balloon, then IVL. IVL has a 4 IVL, 80 pulses given there, right? And a 5 stent. 5 stent deployed at nominal pressures, and then high pressure balloon, and it's a reasonable outcome, and that kind of sitting, like I'm okay with that. Now the last case is again, it's a 52-year-old male, long-standing diabetic. He has been having effort angina for the last 2 years. Suggested angiography a couple of years back. He did not agree, but now he's got rest angina. He had no option but to get an angiogram done. RC has got a bad disease, like starting from like near ostial till the crux. Distally, there's some spontaneous dissection also you can see. The left system is again, the circumflex is a small vessel, ramus is fine, LAD has got bad disease. So considering all that, discuss the plan that he should go for surgery because it's a young patient and like all bad lesions are there, why not surgery? So he did not agree for surgery at all. He says, no, so no surgery. If you can do angioplasty, then I will agree, otherwise I will not. It's okay, fine. Then we gave a plan B that angioplasty in 2 sittings. RC is looking simpler of the 2, so let us do the RC today and take you tomorrow for the LAD. Now see this RC. The guide is hanging out, the wires are not going, and we ruptured. Oh no, going back. Right. So on day 1. So this is 6 balloon ruptured there, entering the lesion, doing nothing. No room has been created. So we gave him the night again that look, he might think of surgery tomorrow, but again tomorrow morning he says what time you're doing it. So no surgery. If you can do angioplasty, I'm fine with that. So as usual, we have to take him for like a Rota. The slide's gone. Yeah. Now see the guide. Guide is just hanging out. TPI is in place. And as you are doing that, we are drilling again it's a 1.25 bar. As soon as you touch the lesion, the STs go high up and the wire is coming back. Means there's hardly any drilling happening there. So you had to take some support of the guide. Guide was deep, it was slightly kicking inside so that we have some support for the bar to just make some room there. So after about 6 minutes when it was not going through, we decided that look, we might stop and send him home if he doesn't want to get the surgery done. Then we decided, look, the last time, let us try it once again. But the last time was, I think, is a trick. It happened. But always keep in mind, do not push. You have to just give the bird time to drill, right? So this time this went in, and now nothing is bad. After drilling happens, everything is easy. All the balloons, all the wires go just like the butter. There's no problems. Put in 2 long stents and came out, right? Thank you. Thanks for your attention.
Excellent cases. I know you can keep going on. Comment from Dr. Regi. We have a mic behind you. So we have our expert from Egypt, Cairo.
Thank you very much. Congratulations for the meeting first. This is amazingly educational because what we saw now is cases at an incredible level of calcification difficulty. But when an expert is using the rotablator gently and even knowing when to stop, we don't see complications. And in many instances, in cases like this, you would have seen straight perforations with the burr, or burr entrapment, or many Rota nightmares. And I learned a lot from this presentation and the one before it. Thank you.
Sir, most of the time I haven't seen you upgrading the Rota. First, you use most of the time once only. So you still believe in a lesion modification only by the Rota?
Yes,
Rest of the work has
it
to be
depends
done by
that
the
how
Rota.
big is the vessel and how big a room you want to create.
So
I often
what the first thing
do it.
you think about the sizing of the Rota?
Sizing depends upon the lesion tightness and the length of the lesion. If the lesion is short, you can take even a bigger burr. If the lesion is long and like very tight lesion, take a smaller burr and then upsize in case possible.
So if it is the tight most of the time you start with 1.
Yes, then I go upsize to 1.5, 1.75 even, if it is required.
Any comments on the panel?
Other side,
Yeah, okay, we have one coming in the audience.
Dr. Tyagi.
This is something which has been lingering with me from the previous discussion which we had. Once we see calcium, we classify calcium as superficial calcium and deep calcium. Anything more than 5 mm, it's better done on OCT. And if it is more than 5 mm, we usually try NC balloons. Do you think this strategy is fine?
I didn't get you.
So we usually classify calcium as superficial calcium and deep calcium. If the depth of calcium is more than 5 mm, we start with the NC balloon rather than any calcium modification. So, I mean, with a NC balloon or a high pressure balloon, ultra high pressure balloon.
See, even a deeper calcium, you see, rotablation does quite a few things. Like even the calcium is deeper, if you rotablate that, they become more compliant. So before the balloon, if you know the calcium is heavy, take the burr down, like that will always help you. Without that, it's all barotrauma. Once you are going without Rota in a calcified lesion, maybe you open it up like your opium balloons, and you have seen so many perforations on the lesions which are calcified and they've gone high, 35, 38, 40, 44, and then you have back perfs and are dealing with that. And we are yet to come across a lesion which has been drilled properly and then go with a high pressure balloon, then you hardly any perforations. So these all barotraumas are not very helpful.
Right. So this is because, I remember, a calcium modification algorithm where they start with the depth of calcium.
So these algorithms are only there in a books, you have to follow your own pattern. Everybody develops his own technique. Kirti does it his own way. We doesn't do it in our own way. Dr. Mathur is doing it in his own way. So all the algorithms are just like bookish, you have to just develop your own technique. And we know that at times people say that it's looking all right. So no, it's not looking all right. I have to upsize the burr. So these all things are there, but you have to develop your own technique when you are doing a case.
One more question over there. Thank you.
The cases were very great. And the first two cases where you had that wire bias and bends, what were the wires that you used? Was it the
Floppy.
floppy or the extra support?
We only have floppy wires here. We don't have
Any occasions where you use?
We usually want to use at times, if you want to just change the wire bias, you can use a support wire, but unfortunately we don't have the support wires with us. We have only Rota floppy wire. We don't have any option.
Thank you so much, Praveer, and big hand for lovely cases that you have shown us.